Leggott is a family physician with health politics experience whose expertise includes policy development and translation, the intersection of policy with state-based healthcare legislation, and innovative approaches to addressing healthcare reform. Dr. Leggott seeks progressive and innovative approaches to address health inequities by promoting systems-based and policy-level interventions. Dr. Leggott is an assistant professor of family medicine in the University of Colorado Department of Family Medicine, where he completed a fellowship in health policy and politics. Dr. Leggott is a health policy scholar at the Eugene S. Farley Jr. Health Policy Center. He also serves as a board member for the Colorado Academy of Family Physicians. He provides patient care in the clinic and hospital while teaching family medicine residents and medical students at the University of Colorado. With that, Dr. Leggott, go ahead and take it away.
Awesome. Thank you for the warm introduction. And we are a small but mighty group today, which I hope means we get to have really robust discussion and Q&A. So as I'm going, if you do have a question, feel free to raise your hand, type into the chat. Honestly, if you want to just come off of mute and interrupt me, that's totally fine too. I think we have the space to have an engaging conversation. So today I'm going to talk a little bit about designing an advocacy curriculum for family med residents. This is part of my job as well. I am in charge of our policy and advocacy curriculum at the University of Colorado Family Medicine Residency Program. That being said, nothing I do is in a vacuum. And so really quick, just wanted to acknowledge some of the other team members who help put together some of these slides, but also who run our policy and advocacy curriculum at the University of Colorado. There they are. Okay. So what we're going to do today is we're going to talk a little bit about the role of policy and advocacy in family med residency education. We're going to talk about different components of having a longitudinal policy and advocacy curriculum. In truth, I put policy and advocacy there, but we're mainly going to talk about advocacy curriculum, though I'm happy to touch on both. And then we're going to explore the types of policy and advocacy components that satisfy different levels of the ACGME Family Med Milestones 2.0, which I'm sure you're all very familiar with, and how you can use some of the curricular pieces to fulfill levels 4 and 5 of different components of the milestones. So really quickly, this is just our program at a glance. We are 2 tracks, down from 3, because unfortunately our rural training track did close last year, which is its own separate advocacy adventure that we could go into. We've got 13 residents per year, pretty broad spectrum training. Our 2 main tracks are the university track and the Denver health track, 2 different kind of health systems or hospitals that our residents train in. And it's mainly centered around the Denver metro area, but we do get some experience out into rural Colorado as well. So here's what we're going to cover. Why advocacy? Why do we care? Why do we need a curriculum for it? And I actually want to hear from you all, so prepare to unmute and introduce yourselves. We'll talk about the curriculum that I run and the one that we do at our program and how it relates to milestones. We'll do a little dive into the evaluation component and what our residents think of the curriculum. And then we'll talk about future directions and resources that could help you all either to augment or implement an advocacy curriculum at your own programs. So why do we have advocacy curriculum in family medicine and why should we care? Just because it's in the ACGME milestones is not a good enough answer. So I would love to hear from you all. If you don't mind unmuting and introducing yourselves, maybe tell me where you're from or who you're with, and then what kind of advocacy curriculum experience you have with your residents and or why you think it's important in family med. Joy, you came off of mute.
Hi, yes, I just want to introduce myself. My name is Joy Leatherman. I'm the Family Medicine Residency Coordinator for HMS in Silver City, New Mexico. We are trying to get a rural training track up and running for the area. And that's why advocacy, because people desperately need it.
We do indeed. I call that job security
Yes.
in teaching it, but yes, we desperately need it. Let's see, I don't need to call on people, but I don't know if Jennifer or Gabriella, if you're able to come off the mute.
Hi all. I'm currently in my lunch hour, so I'm not going to show you all that. But I am not part of any residency program or anything like that, but I am a faculty member at New Mexico State University, of which I end up, teaching students that are interested in medicine and interested in nursing and things like that. So part of what I do within the work here is I teach health communication, and I do include portions of policy and advocacy and things like that to introduce students to these. And hopefully, as they start working in their medical curriculum and going into residencies, they remember some of that information and are able to kind of, pack on what they already know. So it's not as new of a concept once they encounter it in medicine.
Wonderful. Thank you for doing it upstream and making sure that students come into medical school residency already learning about this, engaged and ready to do the work that we need.
Thanks.
All right, Jennifer, if you're able to come off of mute, or whoever BV's iPhone is, but if not, no worries. I understand people are either at lunch or sometimes multitasking.
Hi, this is Belinda Vale. But I just got on, so I assume you're asking a question. I assume that you're just wanting to know who we are. I'm the chair at the University of Kansas in Kansas City.
Wonderful. Thank you for introducing yourself. And yeah, the question was, why do we have or need advocacy curriculum in family medicine?
Well, since it said why advocacy on the screen, I thought that might be it. And I thought that was I thought that was really my first answer to that. My first flush was, oh my, because the health system in this country is a mess, and I truly believe after 40 years of doing this that the answer is in family medicine, and we are boots on the ground all over the country, in rural areas, in urban areas, in everything in between, and the health system really runs on our backs, but the money goes somewhere else, and not just to the specialists, but to the pharmaceutical companies and the insurance companies, and to all of the incredible structure that we have developed that has nothing to do with medicine, that just has to do with how everyone gets paid. And we're at a tipping point. It seems to me that we are, because 20% of our GDP goes to healthcare, and yet we have some of the worst healthcare in developed countries. And if we're not the answer, who is?
I love that. I could probably just stop talking right now and just cede the floor, but I love your answer and fully agree with you. And that's why it's probably my favorite part of my job, that I get to teach the advocacy skills that are necessary so that the future generation of family physicians can be those change agents to make a difference. Wonderful. Thank you. All right. Well, those were great answers. Thank you all for sharing. Written out, this is just verbalizing some of what I already heard. My own take on this. I think at its core, advocacy is a part of our professional responsibility for all physicians. And then I think, to the point that was just made, family physicians are especially situated in our communities and at the forefront and across every community in this country to really be at the forefront of physicians and doing the advocacy work that is needed. There's the practical answer that this is part of our family medicine milestones, and so we have to do it as well. But really, the core of what I heard is that, in today's landscape, it is not enough to be a physician to provide excellent care in a clinic or a hospital. And we know that the majority of what affects our patients' health and well-being happens outside of the clinic and hospital walls. And that the way that we get to practice medicine, the way that our patients get to access care, is deeply influenced by policies and decisions that are being made outside of our control. And so as we develop these skills to be physician advocates, it allows us to better impact the upstream policies that are going to negatively impact us, our colleagues, the healthcare system, and our patients. Yeah, this is just saying that if you, as you incorporate different components of a longitudinal advocacy curriculum, it's pretty easy and achievable to hit levels 4 and 5 of SBP2, SBP3, and SBP4 in the family medicine milestones. And that, at least in my experience at our university, the advocacy experiences that our residents get to do and the trainings that they do tend to be some of their highlights of their training career. So really happy to see that with our residents. This is the AMA Declaration of Professional Responsibility for Physicians. I think it's a nice, 2-sentence summary of what we just said, but I'll just leave that up there for a moment for you all to see. Okay. Most of you have probably seen this. This is from National Academy of Science, Engineering, and Medicine. This is just showing that the vast majority of things that impact somebody's health outcomes, as we talk about length of life, quality of life, happen outside of direct clinical care. But we care about them as physicians and especially as family docs. And so we do care about these social and economic factors, the physical environment, the health behaviors and policies that impact that. And we care about the policies that impact our clinical care, even if it's only 20% of health outcomes. The point being here that advocacy occurs at many different levels. I think most physicians have a lot of experience being advocates at the individual patient and clinic level, right? I personally believe that fighting against a prior authorization for a patient to get the medicine they need is advocacy, and that's advocacy for an individual patient. And we oftentimes see advocacy happening at a clinic or maybe an academic department or a hospital or a system level. But we know that advocacy can impact or be done at the community level, state level, national and international level, and a lot of spaces in between. And I would argue that the scope of the advocacy that you do in these different spheres changes, but the skill set that you would use to affect change is the same. And so really in our curriculum, we try to focus mainly on skills-based workshops and skills-based curriculum, because we know that our residents and our physicians are going to advocate at different levels and for different things, and we want to give them the tools and the skills to be effective. So I'm going to dive into what we do in our curriculum, talk through the workshops, and we'll go from there. So our longitudinal advocacy curriculum is nestled within our FACE curriculum. That stands for Public and Population Health, Advocacy, and Community Engagement. So it is one component of a larger nested longitudinal curriculum that really looks at those other aspects as well. There's just some pictures of our residents doing things within their FACE curriculum, and it includes workshops, lectures, presentations, hands-on experiences, travel, field trips, lots of things. This, you can see the kind of elevated green blocks is when our residents get dedicated time for these longitudinal curriculums, this FACE curriculum, and you can see the circled boxes are when they get dedicated time for the advocacy workshops that we're going to dive into in more detail here in a moment. They get some at the end of their intern year, at the end of their second year, and then quite a bit in their third year as well. Their third year is a little bit more project-based, which is why those 3 blocks are kind of spaced out, since it's experiential and project-based. So this is just the names of the workshops. We're going to go into them in a bit more detail. But in intern year, our interns get 2 skills-based workshops around advocacy. One is kind of Advocacy 101 and policy mapping. And then the second is advocacy and leveraging narrative or storytelling. In year 2, at the end of the year, they get 2 workshops around advocacy skills. One is legislative advocacy and communication skills, verbal communication, and then the other is advocacy skills through an op-ed workshop. And then in that third year is really when they're taking the skills that they learned in their intern and second year and then practicing them out in the real world. We'll dive into what each of those are. So we start our advocacy curriculum with what we call the Advocacy 101 and Policy Mapping or Magic Wand workshop. It has a little bit of an introduction. What is advocacy? Why do we do it? I can tell you that in the past, we used to really harp on this is why advocacy is important. And what we found both from feedback and experience is that our residents are coming into medicine already knowing that. they already have identified and maybe even self-selected to realize that being an advocate for patients, for their community, is a core part of what they want to do. And so we no longer have to spend a lot of time about convincing them why it's important, and instead asking them how they want to spend their time in residency and beyond being advocates and change agents. So in this workshop, we go through a skill called policy mapping, which is really this idea of defining a problem and then developing out how you would go about creating policy solutions and implementing those policy solutions for the problem. And we oftentimes ask the residents, hey, if you had a magic wand and could wave it and change one thing that you found in residency that bothers you as a physician, what would it be? And the scope and scale of the problems that our residents try and tackle through this exercise ranges from appropriate discharges and transitions of care from the hospital for patients experiencing homelessness, to access to affordable prescription drugs, to one group who wanted to change the US Constitution for reproductive health rights to be a core enshrined piece of the US Constitution, and everything in between. So it's really fun that they get to scope and scale the problems and the solutions based on this kind of workshop. The second workshop that we do is called Advocacy and Leveraging Narrative. This is really tying in the importance, demonstrating and then practicing the importance of stories in both advocacy and leadership skills. We use a storytelling framework called public narrative. This was developed by a gentleman named Marshall Gantz, who was an organizer with Cesar Chavez in the labor movements, and still teaches storytelling as an effective advocacy and organizing tool at Harvard University. And so we give them this framework. We talk to them about my favorite infographic in the world, which is down here on the left, which is the idea that if you want effective action and change from somebody, you need to provide them both the strategy, the logic and the reasons and the data, and the narrative, the why, the motivation, the emotional connection. And so we teach them storytelling, and we actually practice telling a story of self in small groups. And the story of self is really a way to share or show to someone your values that define who you are in a moment. And so it's really powerful. And I think our residents, as end of the year interns, get to know each other quite a bit better too as they go through this exercise. So then as we move into our second year, and we remember we get these residents during the end of their R2 year for this workshop. This is our advocacy writing workshop that is focused around how to write an op-ed. So we teach them one of the ways or one of the structures for writing an op-ed: lead, newshook, thesis, argument, evidence, to be sure, and then call to action. And what we do is we will go through that structure. We'll talk about op-ed writing and how it's different than peer-reviewed publications, which they get plenty of elsewhere in the curriculum and in their experience. We will analyze some example op-ed pieces, and then we actually start them writing and practicing their own piece. And I'm really thrilled to say that we've had about 7 or 8 op-eds published in the last couple of years from residents who start it in this workshop, and then I offer to engage with them one-on-one and help them finish, refine, and look for opportunities to publish. You can see on the bottom left here, this is from one of our former residents, Jennifer Camello, who published about the impacts of climate change or climate medicine on her patients. So that came out of this workshop and is a really fun one for residents to get an opportunity to kind of write something that is very different than the peer-reviewed side of academic writing. And then my single favorite workshop is the testimony workshop. So we are in Denver, which is the capital of Colorado, and we are very close to our state capital, and we make sure our residents have an opportunity to engage with our legislators. And so we will run through a little bit about how the Colorado legislative session works, talk a little bit about what committee hearings are and the logistics of testifying in front of a committee full of legislators. We'll teach them about framing and how to make these strong, cohesive 2 to 3 minute arguments. We'll give them a framework for that, which I'll show you on the next slide. And then we dissect testimony from previous years, and then we practice testimony, and they all will individually get assigned a bill and draft 2 to 3 minute testimony that they will then give in front of each other, receive feedback, and refine further. On the right here, you can see the acronym that we use for outlining that 2 to 3 minute testimony. We call it the THINGS acronym, very easy to remember. Thank, acknowledge your committee members or chairperson. You introduce yourself and your ask or your position. You share a little bit of a narrative or a story about how this bill or issue comes up in your work as a physician or your who you are as a person. And then you generalize your story or experience with data, and then you finish with a solution. On the left here, you can see this is our outline or agenda for that workshop, which I'm happy to go into more detail if people are interested in that level of specifics. But it's a really fun workshop, and we every year have at least 1 or 2 residents who then sign up to testify because we are using active bills for them to practice on. And so these are pieces of legislation that are currently being discussed in our state legislature that they will draft an opinion on, practice testimony, and then have an opportunity to go give that testimony in the real world. So you can see some of our residents. You can tell this was during COVID times because all the chairs in the background with the caution tape and all the masks in the room. But this is 2 of our former residents, Dr. Ali Costello and Anita Madurai, who are testifying on the Colorado Prescription Drug Affordability Board, which is around trying to improve patient access to affordable medications in Colorado. And then, after we teach our residents all of these skills through these 4 workshops, we expect them to put them into practice. So our 3rd year kind of activity curriculum or advocacy curriculum is centered around having a self-directed practice with some faculty guidance. We block time for them during the longitudinal curriculum in those 3 months to do this work. We don't expect them to do it outside of their clinical expectations on top of everything else. We try to block them time or comp them time for it. And there's really 4 components of it. First, they will spend half a day down at the Capitol participating as Doc of the Day, where we provide medical care to legislators, staff members, and visitors to the Capitol. And we sit in on committee hearings and just kind of spend some time acclimating ourselves to the state Capitol. We expect them to attend a stakeholder meeting with some advocacy or policy group, and then we expect them to use some form of written or verbal or other one-on-one meeting advocacy on a topic that they're passionate about. They'll then debrief with the faculty. We'll usually do a short write-up and sit down over coffee and talk through their experiences throughout all 3 years, but really focused on this 3rd year advocacy activity. And then that's my opportunity, I mostly do these debriefs, to document their levels 4 or 5 of the family medicine milestones, specifically for SBP3 and SBP4. This is just a slide to show that we have policy and advocacy content outside of FACE and opportunities for them through a bunch of other mechanisms. But really today I wanted to focus in on those experiential workshops more so than the didactic lectures or the electives or those types of things. But this is just to show you that there's a robust amount of other activities that our residents have access to that supplement their policy and advocacy content outside of this longitudinal curriculum. Just going through our SBP 3 and 4, it's pretty easy with experiential advocacy and teaching skills and then having the residents engage in those skills to hit level 5 for both of these. So for SBP 3, physician role in healthcare systems, level 5 is advocates for or leads systems change that enhances high value, efficient, and effective patient care and transitions of care, or participates in health policy and advocacy activities. Second one makes it pretty easy if you have them be an active member and engage in policy and advocacy stakeholder meetings or advocacy work. And then for number 4, level 5 is develops a relationship with stakeholders that advances or prevents a policy change that improves individual or community health. That's specifically why we have them attend a stakeholder meeting, which is a little bit different. And we try to get them to build a longitudinal relationship with those stakeholders in their R3 year. All right, before I go into outcomes and kind of evaluation, I'm going to pause there because I just went through like a whirlwind of advocacy curriculum and experiences, and would love to pause to see if you all have questions or want to have any mini discussion there.
Dr. Leggett, Lynn put in the chat, it says the Colorado Association of Family Medicine Residencies also hosts an advocacy rotation for residents across the state and hosts its own policy committee around primarily state government policy.
Yes, Colorado Association of Family Medicine Residencies is a fantastic opportunity and elective space for our residents. So, you know, as we go back a couple points to those, let's see, this slide here, you know, we really do have a ton. We're blessed in Colorado to have a ton of opportunities for our residents to engage outside of their longitudinal curriculum. A lot of elective space, and certainly CAFMR helps us fulfill those elective opportunities and round that out. But what I would say is the things that I just mentioned before are all part of our core curriculum for every single resident. So whether you decide to take an elective space or not, you're going to get that longitudinal advocacy curriculum and do an experiential residency, or excuse me, R3 activity. Great point, Lynn. Anyone else? Any questions, comments, or discussion before I dive into a little bit of the evaluation? All right, we'll dive forward. I'm going to breeze through this. This is really just showing you what our current evaluation strategy is. Could be more robust. Evaluation's not my strongest suit as the director of this portion of our curriculum, but I do think it's something that we have enough data to show that our residents learn something from this and enjoy it, and still want to be advocates at the end of it. So for this first section, this is looking at pre-post data. For our R1s, this is self-reported confidence in the ability to advocate effectively for health of patients and communities, and advocate effectively for the health of an individual patient. So you can just see on the left side, the lower bars are the self-rated pre-data, and on the right in the red is the self-rated post data. And I didn't put the p-values up there, but statistically significant. So hopefully showing that there's some increase in their confidence and their ability to be effective advocates for both patients and communities. For the evaluation for the second part, this is kind of getting between their R1 and their R2 year. This is, you know, how much do you agree, disagree, Likert scale questions with the following statements. And really what we show here is just that in the first two, pretty much all of our residents agree that being an advocate for their patients and their communities is a part of their essential role as a family doc. And that is something that they firmly believe. It's pretty much 100% across the board. What I do think is interesting is their response to participating in advocacy activities is usually difficult and time consuming. I think this is the reality of being a resident and not having a ton of time and space, but our residents definitely find that participating in advocacy activities is still hard to do. And I think that's just an acknowledgement that residency is a really, really busy time, and it's difficult to try to do that on top of learning how to be a good family doc. This is a little more of that pre-post data around confidence. And this is more confidence and ability around skill sets. So that first question is around confidence in your ability to compose an effective advocacy message. And you can see at the beginning of R1 year is the top bar, end of R1 year is the middle bar, and end of R2 year is the third bar. And hopefully, as they go through more of these workshops, their confidence in their ability to have effective advocacy messaging goes up. Their ability to describe the different ways to participate in advocacy at different levels, right? Individual, patient, community, health system, state, national, international, goes up significantly from beginning of R1 year into the R2, or end of R1 and end of R2 year. And then describing the different levels of advocacy as well. You can see a big change between the beginning of R1 year and then end of R1, end of R2 year. To date, we've had 31 residents who have participated in the R3 advocacy activity since 2021. That is the majority of our residents, but it's not quite everyone. We don't hold people back or keep them from graduating if they don't complete this activity. And then we have had a few residents who, for health reasons or family reasons, have not been able to complete this if they are out or have something big come up in their life. And then we've had 16 of our residents who have submitted mostly oral, but sometimes written legislative committee testimony since 2021 on a variety of bills that range from prescription drug affordability to insurance access to climate health impacts and many, many other topics. This is the last, I think, evaluation slide, just going through how likely are you to participate in advocacy activities after residency. And I show this just because it's interesting to me to see this number drop off at the end of the R2 year. And I think maybe just speaks to the fact that these residents come in energized and ready to be advocates, and then maybe their enthusiasm or the reality of being a family doc tempers them a little bit as they leave. Obviously, this is a single data point from a smallish cohort of residents, but it is unfortunate to see that number drop even slightly at the end of the R2 year. I'm going to go into just some future directions and potential upcoming resources for you all if you're interested in pursuing or augmenting an advocacy curriculum in your program. First, our evaluation data is getting better, so we will have more robust evaluation data around self-rated confidence in advocacy skills and likelihood to participate in advocacy skills post-residency. But maybe of more interest to you all is the fact that we think we have a pretty good advocacy curriculum and workshops at our program, and we are working on packaging those 4 workshops that I went through so that other family medicine residency programs can use them free of charge. And we're looking for open access publication for something like MedEd Portal or something similar, where we can have a facilitator guide, agendas and outlines of the workshops, lecture slides ready to go, and then tips for how to run the lecture as well. And all of that be publicly available for other family medicine residency programs or med student curriculums or non-family medicine residency programs to be able to use those workshops and kind of go through them and use them at your own institutions. So this is just 2 screenshots of one of our working documents trying to outline the facilitator guide for these 4 workshops plus the advocacy skills project. And then on the right side, you can see there what we're kind of in the process of developing: descriptions of the workshops, having learning objectives easily available, and then things like agendas and facilitator prep notes so that they're easy to run for people who haven't done it before. And that is hopefully all going to be wrapped up by the end of this academic year, so kind of mid-2026. So I'd be interested to know, how you might apply what we've gone over today at your own programs or institutions, and then would love to have a discussion with you all as well. So I'm going to stop screen sharing so it's not just me looking at my slides. Any questions, any thoughts, discussion points, or we can get some time back. Go ahead, Joy, you unmuted.
I just think it's really important, especially like in such a rural place that we live in, and the struggles that we're having right now, that people step up to be advocates, to advocate for the people in that are suffering, actually, because our healthcare system is a mess right now.
Fully agree with you, and I think that our residents want to do that, and I think that they're more likely to if you give them the skills to feel confident in their ability to be those advocates and teach them how to do it. But I think they're all coming in wanting to it because they see the suffering day in and day out in their clinical care. I know for me personally, I almost burned out of residency in medicine, just seeing how our broken system fails patients in clinic, in the hospital, and everywhere. And the only outlet, or the best outlet that I found, was trying to advocate for systems changes to make the system better.
Right. And it's not just the patients actually suffering, it's the providers I see as well, and the administrators suffering a lot.
Very good point.
I'm looking forward to June 26th when you have the toolkit available and we can put it more broadly out to the folks in the Plains to Peaks group and others. Kyle, I'm so grateful that you're all taking on that challenge.
You're very welcome, Lynn. It has been a work in progress now for like a year and a half. We're slowly chipping away at it, but we have one of our former residents now at in Milwaukee who is adapting the program for his med students. So he's going to be doing it for a med student advocacy curriculum, I think out in Milwaukee. And so we're seeing people adapt it, and we just want to essentially get it out as a usable tool for other people as well. And then Gabriella, I think I saw you go off mute for a second.
Yes, I wanted to ask, just based on this conversation that you all are having, is part of the curriculum also including self-reflection to avoid burnouts? Because this type of work, I mean, is a lot on top of everything else that you all have going on. And you touched on that earlier, but I'm curious to know what kind of information, if any, is included in this curriculum where, you know, physicians learn, and I know this sounds, you know, kind of out there, but learn the balance between this, because you have to all take care of yourselves in order to be able to advocate for others. Yes. And the amount of work that goes into something like that, I often am curious to know where that is included in a curriculum and how it's acknowledged for them to understand that this is not just another meeting that they're going to, but there's a lot weighing on this and how they can take care of themselves through that.
Yeah, really point well taken. It probably doesn't come through much in what I presented, that there is a lot of time for our residents in their curriculum built in for self-reflection. That is probably better captured under the wellness and well-being curriculum that is separate than what I do. We obviously are aware of each other and things overlap. In this work, what I would say is in the reflections that I do with our residents at the end of their R3 activity, we sit down, have coffee or sometimes a beer, and we reflect and debrief and talk. And most of what I hear, not always, but most of what I hear is that doing this kind of advocacy work actually helps prevent burnout for them and actually helps fill their cup. Because I think many of them feel the stress and strain of providing clinical care inside a broken system. And it's hard to feel like you have an avenue for making change outside of that space. It is also why we don't prescribe to tell our residents what to advocate for or who to advocate for or what topics. Our goal is really for them to find something that is going to fill their cup, so that when they do these activities and these projects, that it is actually helping to combat burnout and is helping to make them less likely to leave medicine. I hope that answers your question, but I don't know if it fully did.
No, it does. I actually appreciate you saying that there is an understanding of what each part is doing. Oftentimes, and again, I'm not part of the medical system. I'm a patient in that medical system. Part of what I notice is a disconnect. It's almost like a siloed type of functioning where everyone is doing their own thing, but there's never really this cross communication that is happening to understand what the other group is doing and how to better improve on that. Oftentimes, at least as a communication scholar, one of the deficiencies, I guess, that we can say in communication is just the lack of sharing this information with other people to build on something that you're already working on, and you know that it has benefits to those that you want to serve. But there's always that component of, oh, well, we really don't know what this other group is doing, but we're doing this. And I appreciated you sharing that there is a collective synergy actually happening for this.
Yeah, but to your point, and I think it actually is a good call out for me, is that I might want to do more to really strategically draw that connection between this advocacy work and burnout and provider well-being and taking care of yourself as a as a physician in training, because I think it happens organically, but it probably deserves its own call out.
Hmm. Thank you for that.
Yeah, thank you. Any other questions, comments, concerns? Okay, then I'm going to hand it back to you, Amanda. And thank you all for your time. I know it's over the lunch hour. You're busy people, and I hope this was helpful. And I'm happy to be a resource if you ever want to reach out and have a one-on-one discussion.
Thanks, Kyle.
Yes, thank you.
Thank you, Dr. Leggett, and thank you everyone for joining us today. I believe there are a few links put into the chat if you would like to take our survey for the presentation feedback, and also the link to register for our December faculty development session, as well as a link to sign up for the NMPCTC communications list. My email address is also in there if you would like to request the recording. And thank you guys so much for being here.